You are listening to the Health for All podcast, and this is your host, Sanat Kumar. I hope you enjoy listening. Welcome to all the listeners of the Health for All podcast. Today, I'm actually delighted to welcome Professor Audrey Chia. Professor Audrey Chia is an associate professor at NUS Business School with a concurrent joint appointment at the Yong School of Medicine as well at NUS. She also is the program management chair of the MSc Environment Management program as well. Professor Chia's research applies leadership, change, innovation as theoretical foundations to address health, environmental, and social challenges. Professor Audrey has made notable collaborations and expert contributions to the UN, ADB, OECD, as well as the Asia-Pacific Leaders Malaria Alliance, right? Between 2011 and 2017, Professor Audrey was also the program director of the NIHA, which is the NUS initiative to improve health in Asia, healthcare leadership program for senior leaders in public, private, and NGO sectors from across 15 countries, right? And I'm also, so excited to tell you that Professor Audrey has had numerous awards, recognitions for her work and contribution across various spans. So thank you so much, Professor Audrey, for making it to the Health for All podcast. As I mentioned, right, it's an honor to have you on this podcast, and I'm looking forward to the next 60 minutes of just pure conversation on health and how we can improve the face of health across the globe. So thank you for being here.
Thank you, Sanath, for your very comprehensive introduction. And I'm very happy to be here and have a chance to converse with you.
Wonderful, wonderful, Professor Audrey. So Professor Audrey, I've read through a fair bit of your publications.
Mm-hmm.
I love the topics
Thank
that you write about. I love the fact that your research focuses on addressability, accessibility, and availability of healthcare, right? But more importantly, what I'd like to start off talking about, you've spent a lot of time in academia, you've spent a lot of time in business, and now you're starting to also, over the last years, see the merging or the collaboration between business and medicine. But what I want to start off with is the role of academia itself, right? The partnerships across the ecosystem as well as the private sector. How do you see that evolving? And what have you seen the journey has been over the last few years?
Yeah, thank you for that question, Sanath. And it's actually $1 million question, or millions of dollars, right, are being poured into academic research every year, right? So that's a question we ask ourselves. And I think in Singapore, especially, you can see there's very much of a focus on having academia collaborate with industry. In fact, there are many calls for research nowadays that require an industry partner. So you see the university itself has set up centers and even programs that bring academia and businesses and private sector together. So one of these is, for example, the NUS Center for Entrepreneurship, where you see, private funders, private equity, venture capital, all coming to listen to what discoveries or innovations have been produced by professors or students. Over in medicine and health, there's a whole translational research building. You can't miss it. It's so tall, right? And we have vice presidents for translational research. And actually, at this moment, as we speak, there's a series on Channel News Asia on translational medicine, right? So we're hoping that this becomes more obvious to the public and, of course, to people who, in one way or another, work in healthcare. So even in our leadership programs, for example, we see people from the private sector coming in to, for example, the business school. So we just had a program with Abbott Molecular Diagnostics. And that's an example of the private sector and Abbott's partners coming in to the business school to have that conversation with academics. Yeah, so there are various ways to do it, right? So it's through training. It's really through these research centers that provide a platform for exchange. And then there's really the collaboration in research.
So that's great. That's great to hear, Professor Audrey. So, there's incubation, of course, right? A lot of incubation happens, a lot of research is happening in academia. And then there's the funding partners that you spoke about. There's collaboration with R&D labs, like you mentioned, Abbott, etc., on how you can move this research, accelerate it, and commercialize it faster, right? So where do you see most of the success in these collaborations happening? Is it as a funding partner? Is it to actually bring research into the R&D portfolio faster, or is it bolstering capability as well of existing private players? Where do you see this mostly seeing fruition?
Yeah, I would say that, of course, can't speak for the whole university because it's very large, but I would say that it's all of those that you mentioned. Yeah. So I have a colleague who works in biochemistry, and he actually does in his lab have people from the private sector working together with our own NUS employees who are researchers, right? So that's a really clear kind of partnership, and they produce the research and findings together, right? And in our competitions, venture competitions, for example, that I've judged, at NUS, we have private sector partners coming in to provide the funding, but also then the advice and the subsequent incubation of these startups, right? So that's really interesting. So let me share with you. So for some years, for example, DBS had a social venture competition together with NUS. And they've since, right, DBS Bank had their own incubator and their own program for following up on some of these startups, right? So one of the startups that I invested in, I judged and I subsequently considered it worthy of investment was Bodhi Health Education. Right. And so Bodhi has been around about 7 years. And after winning a prize in the DBS NUS Social Venture Challenge, they went on, of course, to develop their solution. And subsequently, they have been funded by DBS to continue their growth, right? And now, for example, they've expanded all over India and they've set up a corporate office in Singapore. So to me, that's like a great example of NUS, a bank, and a startup founded by one of our MBA graduates coming together to do some good in the healthcare space, right?
Wonderful. And where is Bodhi now in this journey? I know that they're trying to expand into Southeast Asia as well.
Yeah. So they've set up a small office in Singapore, and they are now moving into the Indonesian market, right? Wonderful. So their solution, I would say, was right now that we've been through COVID, it was prescient, right? So before COVID, they were thinking of a solution to deliver healthcare knowledge and updates to health professionals in a compact and actually in a low bandwidth way, because they were targeting healthcare workers in more far-flung areas. And so there were small packets of knowledge that they could be certified on. It's that whole micro learning example, right? But they were a little bit ahead of the curve, I would say. And so now that all of us have moved on to this bite-sized learning and certification, I think they are poised to do really well.
Wonderful.
And of course, they continue to collaborate with academia.
Did they play a significant role during COVID as well? Because it would have been a good way to actually reach some of the healthcare workers through through training on COVID protocols, training on
Yeah,
specific,
yeah.
comorbidity conditions, etc.?
Yeah, I would say they have been very responsive. So even with the Ebola outbreak, right? They quickly mounted a module on Ebola, what you need to know, right? And of course, with COVID, because it was so, Ebola in a sense was an epidemic, not a pandemic, right? And yet, people were already so fearful, and everyone, including Singapore, we were planning for in case, right? What would happen if Ebola came to our shores, right? And so that actually came to very good use when COVID struck, right? Because it really doesn't matter what infectious disease it is, right? Some of the protocols are basic and fundamental. So Bodhi, yes, of course, produced some modules during the COVID outbreak as well. But of course, we don't have information on what good they did and so on, because it's really about just getting the message out there and equipping people and reminding them, right, about the good practices that we needed to adhere to at that time. Yeah. And I think the good thing is that Bodhi moves fast, right? So even as, if you look at Singapore and other countries, even as protocols or regulations change, right? We change our requirements according to the progression of the disease, right? Something like Bodhi Health can move really quickly, right? And they've gone on now to produce simulations as well, which I think is great because, right, we don't just talk about the present. We have to think about what happens in future, what are possible future scenarios, and how can we deal with them. Yeah, and all that is done in a very nice simulation game kind of way that's engaging as well as mindful. Yeah.
Wonderful. So, Professor Audrey, while we're talking about the pandemic and some disruptive solutions, which Bodhi, likes of the Bodhi, came up with, right? You've done extensive research on organization, change, innovation, leadership. During your time, during the pandemic itself, what are some of the changes that you saw were imperative for leaders to take on, right, in the healthcare sector, right? For them to embrace the pandemic, for them to embrace that change. It will be good to hear what you saw were critical for some of the successful so-called healthcare related companies.
Yeah, sure. I think, of course, key to all that was flexibility, right? Keeping informed and being willing to change. And this, of course, applies to the business sector as well as to the healthcare sector, because again, right, we remember it was an emerging kind of a disease. We all didn't quite know how this virus was going to behave. Sure, it's like SARS-CoV-2, so we know it's that category of viruses, right? But I think we did not expect it, right? And we found out later it's not like SARS-1 at all, right? Because it's right, the SARS outbreak that Singapore, Taiwan, Hong Kong, and Guangzhou and the rest, went through before that.
That's right.
And including Vietnam, right? It was much more short-lived. So actually, on the outside, right, if you remember the early commentary and right, even in the medical journals, right, people were saying, oh, it's going to last a few months and then it will die down, right? So then all of us were preparing with that kind of horizon in mind. And so the leadership was, okay, we'll just bear with this, we'll get through it, and let's sacrifice, because it's just for the short run. We'll be okay, we're getting out of this. And then we realized, oh no, it's not going to be like this. It's not acute, it's chronic, right? So it's going to drag on. And that calls for a really different kind of leadership. Right? Because at the beginning, we just say, okay, let's be gung-ho, let's do it. And so people are willing, right? I'm just making the sacrifice for a few months. But if it drags on and then we realize, wow, this is for the long haul, then it's really about, then leaders need to take the time. Of course, they because at first it was like managing an emergency, right? More things were top down, but later on it became more like, okay, we need to have a dialogue now. What can you bear, right? How are we going to be wearing this PPE for months and months on end, right? How are we going to cope with this? And then, of course, all the mental health issues came up.
Yeah.
Right? And of course, in Singapore, with our healthcare workers, we needed to think, well, how would you feel if you can't see your family or your
Yeah.
loved ones, right? And this wasn't just in healthcare, it was also in business because borders were closed,
Yeah.
right? And so then the leadership really needed to take on a much more listening, dialogue, and negotiation, not in the sense of hardcore negotiation, but we really needed to renegotiate what we can and can't do, what we are willing to do for one another, and how we will support one another, right? And I think this was really new for all of us, right? And plus the relentless, it's like after a while we kept saying, oh yeah, we see some light at the end of the tunnel, right? And then this new strain comes along, right? And so I think the period actually before we had the vaccine, that was really, really tough, right?
Yes.
When the vaccines came, I think people felt, okay, yeah, we can sort of protect one another now. But even then, the virus continued to evolve, right? So we always felt as if we were playing, right, in a way, catch up with the virus, right? And also it was a very fascinating time for me as somebody who looks at leadership, right?
Yes.
To analyze and look at how leaders performed over the long run, right? Whether they gave it priority, how open were they with sharing information, and really admitting we don't know. It's a hard thing for leaders to say. And you have to say, we don't know, but we're going to get through this together, or we are going to help, or we are studying this, we are collaborating, we're talking to people, we're listening to the science, right? And there you see the difference, right? The gap between societies that were willing to listen to science and those that were not, right?
Correct. And I like what you just said, because I think underlying the core is vulnerability, right? Leaders showing vulnerability and the ability to say, you know what, we don't know where this is going, but trust us that we do this together, right? So you spoke about flexibility, you spoke about ability to constantly having that dialogue, openness, and change, as well as vulnerability. And that's pretty powerful, 3 areas that you spoke about. But did you also see anything else apart from these 3 succeed in leaders, right? Help succeed leaders during this time?
I think so the last point I think was to me quite critical. Leaders having a respect for science and being able to talk to scientists, academics, and doctors on the ground, right? Because I think, and of course not just doctors, but with people in the wider community, on the ground, right? You're not assuming that we know everything, because we don't, right? But you see the difference between leaders like Singapore, in Singapore, how doctors, scientists, and of course business leaders and so on were welcomed into the conversation, right? Rather than being dismissed as we saw in some other countries. That makes a big difference, right? Leaders who were science literate, like Angela Merkel. Big difference, right? And even leaders who said, okay, I don't know about science, but here I am with you, and recognizing that it's not just science that's going to heal us, right? And you see religious leaders stepping up to aid the government and the scientists, right, in getting things done, in encouraging vaccinations, encouraging people to wash their hands, and saying, no, you don't have to come to religious services or crowd around with everybody. We are going to give you, broadcasts. We're going to give you blessings from afar. That's just as good, right? And so you see the Pope doing this, and that was really powerful because, of course, there are 1 billion Catholics all over the world. If the Pope comes up and says this, please get vaccinated, please keep your distance from one another, and no need to come to church all the time, right? I think that is really important. And of course, in Asia, you saw how our Muslim leaders stepped up and said, yes, please get your vaccines. That's really important, right? So temple leaders, Buddhist leaders, all these people are coming out to say that. And so what we need is really, it's a test really of any society, how strong those ties are and how good we are at making use, in a way, tapping into all these sources of influence, information, and having that respect for one another, that I think is really important, right? And this actually, I think you see the difference between countries that did well and those that perhaps did less well.
Yeah, powerful points there, Professor Audrey, right? In fact, when I was having a dialogue with a few countries across the region on rolling out vaccines, right? The conversation had to be at the ground level, at the community level.
Yeah.
Who is a religious leader in this community who's driving the decision making or the thinking? Many a times it's not an ad on TV, or it's not a message that you get from the government that you go get a vaccine for. It's somebody that you really trust, and finding that influence of trust and your influence change is extremely important for you to have a successful change in the society. And I totally agree with you. I was in India a few weeks back, and I was talking to a few healthcare providers over there. And it so happened that they were sharing some of the stories that their nurses went through, right? The nurses lived in apartment complexes in the community, where the apartment complexes said, listen, you may be doing a great job in your hospital, but sorry, you're not allowed back home here because you're a risk to all of us. And that was what every single healthcare worker was facing in many parts of Asia, or even larger parts of the world as well, where they were almost treated as disregards, although they were the frontliners. They were the ones actually fighting, right, in the midst of so-called this pandemic. But that's where the leaders had to have that conversation. Like you rightly said, the dialogue with each of these nurses, technicians, and healthcare workers to say, what is it that we can do for you so that you don't feel this disregard, right? So that dialogue is so important to have, right? And how can we alleviate some of these concerns by micro initiatives, providing them space elsewhere so that they can alleviate some of these concerns. But powerful point of view from you as well, Professor Audrey. Moving slightly towards, we spoke about the leadership. We spoke about the importance of leadership during this time. But there's also a big call out now on how can we predict a pandemic? How can we make sure we predict something? And of course, there are a lot of initiatives that are going on that as well, right? But at a patient level, it's come down to, let's also understand preventive health better, right? Let's start to look at your aging population better, right? So tell me a little bit more about how your research in NUS is trying to address that part.
Okay. Well, I think we all know Singapore has the second fastest aging population in the world. We're always very happy to say we have one of the top airports, top universities. We don't want to be known for top aging, but that's where we are, right? So it's been a reality in Singapore, for us for quite a while now. We could, you can see it coming. And I think various sectors of society have been trying to address this, but it has really, I would say, come to a boil, right, in the last few years. So I'm in my own small way, right, with some student projects, we've tried to look at the wishes and hopes of future elderly. In my own work on social innovation and entrepreneurship, I'm always trying to look for solutions, right? And I think social entrepreneurs have a great way of looking at the world, because they see the world, even in what is traditionally resource poor, as resource rich, right? There's wisdom out there, there's experience out there, there are people who know how to cope with difficulties, right? So we did a quick scoping review on innovations for the elderly or for aging across the world. This has not been published yet because it's very wide-ranging and laborious, right? This morning, actually, I just had a conversation with Professor David Allen. He's one of the leaders in developing the health district, right? And we talked about what would be needed in not just research, actually, purposeful employment, purposeful longevity, and keeping productive, and making use of what we've learned in our lives in our older years, right? And the whole idea that a society like Singapore can really tap on that, because what's the point, right, of someone retiring and then just spending a whole lot of time playing golf or playing mahjong or whatever it is, right? I think the future elderly, I think people like me would want to work even beyond retirement, because we still have a lot to offer, right, post-retirement. So that's the point, right? How can we capture that value that is still there? So I'm really excited about this, because the health district has been featured in the Wall Street Journal as one of the top innovations around the world, right? About what's been done. So it's still, I would say, in its early phases, but that's where you see academia, government, private sector, and citizens coming together to shape an environment that we think is going to be good for keeping people healthy. So that's the preventive and public health part, right? How do we keep people healthy and have them stay healthy and productive and happy for as long as possible? So there's, of course, health promotion. The Housing and Development Board is involved because, of course, they build housing and estates. And the whole idea is, of course, they're working with people from design and environment on how to design a health district that encourages people to walk, encourages people to get together socially, right? And encourages people to enjoy greenery and things that are actually good for mental health, right? So how you expose yourself to daylight, greenery, friends, maybe even grow a few veg to make sure we have enough vegetables in our diet, right? So it's all these small little things that really count. And of course, having access to all these groups that have activities, like whether it's dancing, gardening, cooking, whatever it is, right? To keep oneself active and connected. I think social connection is very important as one ages. Health.
Is there like so right now the health district, where is it in its journey? You did say that it's in the initial stages, but who's the population that will be so-called
so sorry, I forgot to mention that. So is the population. So the health district, right now the academics and the public health professionals and all who are involved are from the National University Health System. So National University Health System is one of the 3 healthcare clusters in Singapore, and it's divided sort of geographically, right? So the health district falls within the National University Health System's area of work, and it will include Queenstown Estate, and from the older part of Queenstown, from say Thailand Halt and Commonwealth area, where perhaps we've had public housing for about 40 years or more, to the newer parts of Queenstown, the middle-aged part of Queenstown, like more estate, and then all the way to the newer parts like Dawson that have been actually redeveloped in Queenstown in recent years, right? So that whole area has about 100,000 people who are over the age of 60. And so the health district is a bit like a social or living lab, looking at interventions that we think, so it's all testing, right? Which I think that's what is interesting, and getting input from the community on what they would like to see, working with the NGOs and voluntary organizations on the ground to share their experiences, and also trying to bring in the private sector that has had experience with older workers, and either getting them to offer jobs or stints, but also to give advice. So I think it's very interesting. I would say I'm not involved in a big way because this is a huge initiative. So there are all these different work streams and so on, right? So the one that I just recently got involved in is the one on work
Work-related.
and employment, right? Because I think work is such a big part of our lives. And actually, for a lot of people, it's a source of income, it's a source of social interaction, and also a sense of purpose, right? So that's very important. And the whole idea is, how can we offer work that is flexible and yet enjoyable and keeps people active in their maybe even post-retirement years. So we're just looking at how we can meaningfully engage people post-retirement. Work has so many advantages. It keeps people connected to the community, gives people some income, and it also gives people a sense of purpose and a sense that they are contributing. Yeah, so that staves off all kinds of decline, right? Whether it's social, physical, or cognitive decline.
No, the conversation on aging care is rampant now, right? And across Asia, a number of markets have, increasing number of percentage of aging population. Countries are taking, active measures on what do they need to do for their aging population, right? And, very widely said, like, a country's progress depends on how it treats and values its aging population. And that's I'm glad that it's starting to open a lot of so-called conversations and dialogue on this front. And like you rightly said, it's the entrepreneurs and the startups who are actually seeing the light in all of these small areas where we are not able to, as large corporations, governments, etc. Right? What is important right now is, we're also seeing, just the health district is great, right? It's a great initiative, and as you rightly said, is becoming an example in many ways to the world on what to do from an innovation standpoint. And Singapore is slowly starting to become an example for a number of different things, right? And for example, the biotech hub that we are trying to create in Singapore is the Kendall Square of Southeast Asia, right? And that's also being spoken about heavily. Taking a slight segue now, Professor Audrey, into we've all been bitten by the digital syndrome, right?
Oh yeah.
Everything is digital. You and I are, meeting for the first time, as well as
and all our listeners too.
Everything is digital, right? So going by just digital and how health and digital is slowly starting to become, although in my personal opinion, I think it's one of the industries that has been the slowest to adopt digital. Of course, given the complexity, given the trust, given the data related, security issues, etc. But we're increasingly seeing the use of digital, VR, robotics, etc. Right? So where, with of course health district being one of the case and examples here, but how do you see the change in leadership needs to happen to ensure that we are also fast enough to adopt certain digital as well as digital avenues and practices in health?
Yeah, I think what's great is that COVID has made us embrace digital in a really quick way. So in healthcare, for example, right, telemedicine was very much aided by COVID. And so our National University Health System, does have telemedicine across different programs for chronic diseases, especially. And also the whole idea is that we want people to age in the community, right? Since you talked about aging, it's not so great to have people in nursing homes. And I don't think, it's especially attractive to the elderly either, right? So most have actually expressed a preference for aging in the community. And that's actually the best thing from an evidence-based point of view as well, right? So that's where digital comes in, right? And so we see telemedicine. We have a healthcare to home program. So where this is not exactly telemedicine, but it's where instead of going to the hospital, the healthcare provider goes to people's homes to visit the patients.
Yeah.
And of course, this information, right, is all recorded digitally. So there's been a big push in Singapore towards electronic medical records and so on. So I think, the software has also improved to help us along with the digital push, right? And I think because of COVID, many people have turned to digital. This is so-called safer, right? It's cleaner. You don't have to go out. And so I think that has pros and cons, right? Of course, we still have some people who are not comfortable with digital. And doctors sometimes worry they might miss out symptoms when they're just seeing the patient on the screen, right? So you said rightly, maybe healthcare has been a bit slower than other industries to adopt digital, and that's traditionally also because healthcare has been a very high touch kind of industry, right? So as we get more and more used to it and we become better, and we are helped by maybe on-point diagnostics or apps or reads that people can actually use on their own to supplement. I think we'll probably move along quite.
And you see, because the interfaces here is the patient, there's the nurse, the technician, the doctors, and of course the executive leadership of the healthcare companies itself, right? So of course there's a leadership, the skill, the change management. For them to actually be much faster in the adoption, right? What aspects are you seeing are increasing when it comes to leadership?
Increasingly important. Sorry, I forgot to answer that part. Well, I think it's really important to know what can or cannot or should not be done digitally. Sorry. So maybe we can, but we shouldn't, because I think, and also to recognize that, with any innovation, there are always people left behind. There will always be people who, for example, cannot use a digital interface well or are not good at it. So there will be these people who will not be going along with the so-called digital revolution, right? And these may be the ones that we need to visit more at home or see on site, right? The other thing that's really interesting with digital is also that there's a push towards care in the community. So NUHS now has polyclinics and is working more with primary care physicians. So to maintain that high touch, right, it's these primary care physicians that have to be brought into the network, right? So the whole idea, I think, about leadership now is that it's really very much leading of a network with people who are not trained, for example, in healthcare, needing to work with the volunteer organizations that might perhaps go in and help you check on a patient, for example, right? So, and it's about increasing the health literacy and health knowledge about the population as a whole, so we can look out for one another, right? So I think that the aspect of the network and collaboration is really important. And recognizing the role of social factors, right? So we talked about that a little bit, when we talk about religious leaders and so on. But I think it's so much more important when we are actually looking after a population that is aging, right? And so we talked about work, right? We can talk about it all day, but if companies are not willing to employ these older workers, then we're done, right? There's only so much entrepreneurship that we can do, right?
That's right.
So, but if around the community we recognize that people can be employed in a flexible, in a productive and contributing way, then that's great, right? And it's borrowing ideas from all over. Like, for example, having a grandparent give counseling to a teenager, right? That can be very interesting, and that's been applied in other countries as well. Right? Having the elderly tell stories to little preschool kids, So things like that, right? And I think so. Leadership has to be, I think, creative, has to be collaborative, and it also has to make a judgment. Make a judgment call about where we will go digital and where we will not, and maybe recognize who is left out and be. This is something that we always talk about. Look out for the unintended consequences of going digital, right? So these are some of the things, because for example, we've all gone app crazy, right? And I was at this health startup competition. They did this nice app for encouraging people to monitor their diabetes. Okay, that's good.
Yeah.
Right. And then they said, we put a game there. We gamified it so that people want to spend more time on the app and report and so on. Then I said, well, actually, if you're managing diabetes, you really want to get people moving. You don't want them to be playing your app game all the time. That's not good, right? And this app was actually meant for children who are, have diabetes, right? So that's what we mean about unintended consequences. We say, we want to digitize everything, right? But are we getting them more addicted to their phones, getting them more sedentary? And are we causing eye problems, in that process, right? So I think we have to understand how digital can complement and also recognize the unintended consequences.
You've been all your research, Professor Audrey, you've been very clear. You've been very you've provoked a lot of conversation, right? Your latest paper published on why is dying not seen as a diagnosis, right? A fairly thought-provoking paper. And I read it a few times to actually think about
Thank you.
about it myself. Say, okay, how can this be really applicable? Because it is very, very powerful. And if I may just read a small little snippet from that paper, which I thought was very powerful.
Sure.
The drips, the blood tests, scans, and attempts at scopes were stopped, and it was time to go home. Her medical team found this decision hard to accept. They pressed me to persuade her to allow just one more test. I told them my mother had suffered enough and needed to rest. She received palliative care and died peacefully a week later. In that one paragraph, I really felt you packaged a lot of things, both on care, on dignity, on the ability to accept, and the need to accept.
Yeah.
So, tell me a little bit more about this paper, right? So that our listeners can know a little bit more about the paper.
Yes, thank you, Sanath. Well, I hope everyone will read it. It's only one page actually, and I wrote it because I felt it's something that a lot of us will go through as our parents age. Yeah, and I think it's all about trade-off, right? So much in life is about trading off, and also knowing when to stop. Right. It's the same with, we talked about digital. We have to know where it ceases to be useful or productive. Yeah. So in my mother's case, she had been a patient for so many years. She started, right? She was ill with arthritis even in her 20s, right? So she had been, I would say, treated by the medical system, and the doctors knew her because she had been a long-term kind of a patient, right? And I think she was special to them. Of course, she was to me as well, right? But I think it's very hard in any profession to let go, right? And even personally, because they had known her for a while, and they had so many interventions to keep her mobile, active. She saw her grandchildren, right? And so there's a lot of pride in that, right? And you always think that because she's gone through so much, so many operations, so many debridements, so many treatments, she's survived so many episodes. You could do some more, right? And I think after a while, it became clear to me, and actually to a couple of my doctor friends, and look at my mother, that there wasn't very much more that could be done. And my mother herself actually voiced this. Right? And so then we made the decision that this is it. That's enough, right? It's time to let people go. And there's suffering in all these things about being poked by needles and, right? being asked to do tests that you could not possibly take, right? And so I wrote in the article about how she would have to swallow 2 liters of PEG fluid before going for the scan, right? And you can't do that if you have lost your ability to swallow, right? So it's about being realistic and also thinking about care as care. Care doesn't always have to be invasive. Care is about giving the person the dignity, making them comfortable when you have done your best, and also allowing the patient and their family into the decision, right? So we always talk about patient-centered care and shared decision-making, and I think, I wrote this case because it shows it's so hard to exercise that towards the end, right? And especially in a society like Singapore and probably India, where people think, doctor knows best. Right? And where in the end, right, you have to make that decision yourself. It's your call as the patient or as the family member and the group of you. So what I really liked about this healthcare team is that there was always a lot of conversation, a lot of dialogue, maybe some begging towards the end, right? But I think it was great because at the end, my mother, my sister and I, we were the ones who said, okay, we're done. So thank you very much, right, for all your efforts. But this is it, no more. And it's really hard to take. I mean, I felt bad for my mother's physician because it was difficult for him to let go as well. And I think I asked the question, why is dying not seen as a diagnosis? Because we could actually see the signs, right? The fluctuations in temperature, the inability to swallow, loss of interest. Those are actually all signs of dying. But I think while we were in the thick of it and everyone was trying to see what they could do, perhaps we did not see these signs as clearly as we could. And this paper aroused a lot of interest from all over. I was hearing from people, I was hearing from doctors. It caused a lot of outpouring of emotions and sharing. And many of the doctors who wrote to me said, this is so true. Actually, dying is the diagnosis. But we're just afraid that people will take advantage.
That's right.
It can be misused. There's so many ethical problems. And of course, the system and the way that healthcare providers are trained is always to try to rescue, to revive, right? And I think especially with an aging population and people who have lived with disease for so long, right? We have to revisit this question. No, dying is still not seen as a diagnosis, but I think we have to recognize the march of death. And it's all there. It's actually in the medical literature. The signs of dying, right? And we have to accept that up to a point, a different kind of care needs to step in. It doesn't mean we give up, right? Because maybe for a lot of doctors, this is it, we've given up. It's not. We have to make sure the patient is comfortable to the very end. And that in itself is really valuable for both the patient.
No, I think you bring up a good point because I think the biggest risk of making this a clinical practice is, of course, misuse. I know of multiple cases, both in and around this family circle or even outside, where there was a conscious conversation with the doctor to say, listen, if you really think that health or his or her health, will not improve post this grueling surgical procedure diagnosis, can we just have him or her live peacefully the last few years or few months that the person, right? And it's been, the dialogue has either been initiated by the practitioner or it's been initiated by the family in many cases. But I think the question is making this a policy or making this a clinical practice will require stringent control.
Of course. And checks and counter checks, right?
Counter checks to ensure that this can be a practice. right? And I do believe in the right, for certain clinical risks, for certain, it's fairly straightforward, right? For others, it becomes a huge gray area. We know people sit, in coma for over 20 years, right? Sitting in lying down in a hospital in coma, right? I know cases,
and suddenly waking up, right?
right. And there's nothing that we can do about that because our clinical practices don't allow us, or policies don't allow us to do anything. But fascinating. Thanks for sharing that very personal story, Professor.
Thank you, Sana. Yeah,
right?
thanks for listening.
I do know that the entire clinical community and healthcare community is constantly thinking about, after you did publish that paper of yours, it's triggered so much conversation, right? On what needs to be done in the face of so-called death. I think how I'd like to kind of navigate this last part of the podcast is, based on all the experience that you've had, the interactions that you've had, what's in your perspective, the 5 important aspects that need to be addressed for increasing ecosystem partnership, collaboration, for us to really address access, affordability, accuracy and availability of healthcare, right? What are those critical things that we need to address as a community?
Yeah, thanks for that question. It's really deep. It will require a whole other session, but anyway, I think because I'm in education, I really see the need for, how we start in school, right? And to think about, for example, at university education or high school education, right? I think having breadth is important. And I know the higher up we go, the more we specialize. And somehow specializing takes away that breadth. And it also narrows our social networks and our circles, right? And that makes it really hard, because then we are not able to understand or speak the language of people who are outside our usual sphere, right? And so I think we really need to start with that. And so, for example, our medical school and even the university itself has looked at broadening education, right? And it's maybe a little bit easier in business. We have students taking courses in biology and art and so on. In the medical school, is really interesting because medicine, of course, is very professionalized. Students have been exposed to things like entrepreneurship through the Medical Grand Challenge. They've been exposed to topics like community leadership, where they are encouraged to go out and do community projects and so on. And these are actually seed funded by the medical school. So I think that's vitally important. Even before we start thinking about access and availability, who is it we're trying to give this access to? And who is actually out there, right? We have to go out and see it and know what is out there. And the thing is also, we should be looking beyond our immediate community. I'm a big fan of global health because I know there's so much to learn outside of Singapore, right? In Singapore, we are lucky. We don't really have broken infrastructure, right? And we don't have far-flung areas, right? Woodlands is quite so-called far. It really isn't, right? We have a very good MRT train system and transport system, right? But going out into countries like India, looking at the Philippines or Indonesia, which are so geographically dispersed and split into so many islands, right? That's where the big challenges are. And I think that's where we can learn most about access and about availability, about affordability, right? Looking at examples from Africa, right? So I think broadening our horizons is really important. And it's not just about reading about them in a book, right? So I would encourage everyone now, travel is back. Go out and please don't take a typical holiday. Go out and really go and see, what is out there in terms of access, availability, affordability, right? And converse with the people on the ground, because they are the ones who have survived. They have actually been coping. There are a lot of solutions out there that we have not documented yet. So I think that's really important, to get that first-hand information, talking to people on the ground. And then seeing how we can complement that with what we know in terms of access, availability, and affordability. I think, people still need to wrap their heads around it.
Yeah.
Again, what is affordable to us in Singapore is not affordable to people in other countries. And Singapore just became number one again on the list of most expensive cities in the world, right? So
exactly.
But it's really not the same, right? And I wish people would go out there. I mean, that's where I gain the most. Just looking at people who live in certain conditions far out and the kinds of solutions that are adopted and the wisdom that exists in those communities. It's very humbling and very educational.
And you're seeing a lot of the thinking and the research that happens right now in US. Is it for outside of Singapore as well, in terms of how can we serve the larger need of public?
Yeah, we have to, right? I mean, we can't call ourselves a leading global university.
Exactly.
And of course, our students come from all over. So we had better know about all over, right? Because we don't want to look ignorant as well. And we want to be able to draw this information out of our students who come from Myanmar, come from Nepal, come from India, China, Indonesia, Thailand, Vietnam, you name it, right? We have students from everywhere, and of course, even from South America and so on. So we need to learn from them. And it's great because we have these master's programs, we have executive education. We need to learn very quickly from everyone whom we come into contact with, just like how I'm learning from you now, Sanav.
Likewise, Professor Audrey.
Yeah.
Wonderful. No, I'm super thankful, right after Thanksgiving as well, that you're on my podcast, right? But thank you very much for your time, Professor Audrey. It was an absolute pleasure, right? I didn't even realize how we spent the last 60 to 90.
Yeah, me neither. Yeah.
It was an absolute pleasure.
Thank you.
I learned so much about so many things, right? but look forward to having you again on the podcast for a different topic, right? Because you do so many different things that I'll have to have 100 episodes just dedicated to that.
Yeah, sure, Sana. Thank you. It's been an absolute pleasure. And my name, Chia, actually is thanks, the word thanks in Chinese. So yes, I give thanks every day. And yes, thank you for having me on this podcast. And I want to thank everyone who's listening as well. Yeah.
Yes. Thank you so much.